morning, everyone. All right. Sorry, a little bit nervous, so bear with me. So welcome to today's lecture, our presentation on unusual side effect of acyclovir causing junctional rhythm. Our objective today is to shed light on uncommon but significant adverse effect associated with this acyclovir usage, particularly junctional rhythm, and underscore the importance of the cautious monitoring when initiating patients on such medications. So let's begin by discussing acyclovir, which is a well-known antiviral agent primarily used for treatment of herpes simplex virus infections. While generally considered safe, it is crucial to acknowledge the potential for adverse effects. Commonly reported side effects include malaise, GI symptoms, elevated transaminases. However, more severe complication, although rare, can occur with IV administration, such as acute renal failure and neurotoxicity. Among these adverse effects, sporadic cases of bradycardia has been reported. So now let me introduce to you a case that exemplifies this unusual side effect. We had a patient, a 42-year-old female, presented to our emergency department with a severe 10 out of 10 worst headache of her life, associated with nausea, vomiting, dizziness, nuchal rigidity, and with some abdominal pain. We did a CT head without contrast that showed about a stable 9mm meningioma. While considering a broad differential for the symptoms that she presented with, we included meningitis, migraine, or intracranial hemorrhage. We started her on empiric treatment, including vancomycin, rocephin, acyclovir, and dexamethasone. So one day later, the patient started complaining of chest pain. So that led us to do a cardiac workup. The EKG that you see on the first, it's a normal sinus rhythm that she had about 2 days before presentation to the hospital. The next one you see is the one that she had when she was complaining of chest pain. The EKG showed junctional bradycardia with a heart rate of 43. So cardiology was consulted as patient did not have any prior cardiac history. Extensive evaluation was ruled out to eliminate other causes for a junctional rhythm, including cardiac workup, other medication side effects, attributing to this bradycardia or the junctional rhythm. So what we did is we used Naranjaro probability scale, which is a method to assess whether there is a causal relationship between an unidentified clinical event and a drug, using a simple questionnaire and to assign the probability scoring. A score of 9 or greater defines a definitive cause that the drug might be causing this event. A score between 5 and 8 gives it a probable definition. Our scoring system showed that patients scored about 7, making it very probable that this drug could be the possible case. So we reviewed the literature, and it revealed 2 instances where acyclovir was linked to bradycardia, but there was no documented cases of junctional rhythm in this. There was a phase 4 clinical trial by FDA that identified about 1,400 patients that were taking this medication, and out of those, about 6 individuals, which is about less than 0.5%, reporting bradycardia, primarily observed in males that were 60 and above and has been taking this medication for less than a month. However, still no cases of junctional bradycardia was reported. So for our patient, we managed her symptomatically and with discontinuation of the acyclovir, which led to the resolution of the symptoms. And on a repeat EKG prior discharge, patient went back to her normal sinus rhythm. So the absence of documented cases linking junctional rhythm directly to acyclovir administration, given that she was given oral acyclovir, prompts a discussion regarding the need for increased awareness among healthcare providers, given that it's a very common drug that's used in inpatient setting. So in conclusion, this case underscores the importance of recognizing and monitoring a rare adverse effect such as junctional rhythm when prescribing acyclovir, even without patients with pre-existing risk factors. Early detection and appropriate management, including discontinuation of an offending drug, are essential for optimal patient outcomes. So by sharing these findings, we hope that we can contribute to the collective knowledge and promote safer practices in clinical setting and promoting good healthcare outcomes. Thank you so much for your attention. I'll take questions if you have some. So she was having right upper quadrant pain. We did an ultrasound for her. It was non-conclusive. We did CT abdomen. It was nothing pinpointed for the abdominal pain. And abdominal pain only lasted while she was in the ED. When we admitted her to the floor, she never complained of the pain again. Yeah, we did. Because the reason why she came in with 10 out of 10, worst headache of her life. We were very concerned. She was tachycardic. She had tachypnea. She had leukocytosis. So we wanted to make sure that we are not missing anything. So first we did a bedside ultrasound, and then we followed that up with the CT done by the ED providers. Wide count was about 13,000. Any other questions? No, the lumbar, we were concerned for meningitis. That's why we started her on medications. So her CSF analysis, all within normal limits. Opening pressures was within normal limits as well. No cardiac history. The only thing that she had a history of significant, puts her in an immunocompromised state, was she was on methotrexate for DMARD rheumatoid arthritis treatment. But besides that, she was pretty much very healthy person. Yes, sir. Yes. Good question. So this patient, we are very familiar with this patient. The patient had vancomycin, rocephin, and dexamethasone on a prior admission. The only thing that was new for her was acyclovir. And vancomycin, rocephin, dexamethasone, there's no reported cases of bradycardia. The only other cause was acyclovir. When we consulted cardiology said that this is junctional rhythm, and they have seen bradycardia associated with the acyclovir. So we did a literature review, which showed like 2 reported cases and some sporadic bradycardia. So that led us to believe that, okay, let's do elimination. Let's take off acyclovir first. Once we discontinued the drug, within 36 hours, patient went back to her sinus rhythm. Chest pain never came back. So meningioma was already there. Patient was aware of it. That's something that we did not know. Patient said that it has been stable. We reviewed it and it was stable. It had not grown in size. Neurologically, she was intact. There was no physical exam indicating that this might be causing from the meningioma. Yes. I personally did not, but I was there when they did the lumbar puncture. The ED physician did that, yes. Thank you.